Start the recording.
Oh, sure. So I can kick everything off and then I'll pass it out of the way and I will get out of the way. So welcome back, everybody. I know folks are still piling in. It's the magical 12:16 hour. So it's that time. So quick update. I know a couple people have asked about, are we seeing the surge in what they're now calling the summer surge of COVID cases? The answer is, not really. So I would say at least locally in the Finger Lakes, I would say there's really not a surge at all. And many of the hospitals really have no COVID patients at the moment. If you look nationally, there is exactly 12% increase week over week of COVID admissions. However, it's good to keep in reference. Last week, there were 8,000 COVID admissions nationally. That is in the face of the lowest week since the pandemic started, being the week of June 24th, where there were 6,300 admissions nationally. So yeah, it's still a thing, but in the entire continental or entire United States, we're still only talking, 8,000 people, which, okay, it's still 8,000 people. I don't want to poo-poo it. In the same time span that week ago, there were 176 COVID-related deaths. If you go back to the peak of the pandemic, there were just under 16,000 in a week. So in the grand scheme of things, we are still seeing a very minutia of what we saw before. For those who are following at home and like to be full on nerd, the largest circulating variant is now EG.5, which is still an Omicron variant. It has developed a new spike protein mutation. It makes up 17% of the cases in the US that were reported last week, which is the largest circulating variant now. It is still responsive to the COVID vaccine and booster that is currently being circulated. So nothing terribly exciting. We haven't genetically shifted or done anything amazing. And we are in that phase where it appears that this EG.5 is no more contagious, no more easily transmissible, and no more severity of illness. So it's more just wearing a new shirt that looks just like the same one that we saw before. So nothing terribly new and exciting in the land of COVID. So fortunately in the Finger Lakes region, we are somewhat protected. Where in the United States do you not want to be? Not just this week, but maybe forever. West Virginia, which has seen a 60% increase in cases of COVID in the last week. So not the place to hang out right now. If your plans were to go to West Virginia, perhaps look somewhere else.
Would you believe it that I am spending a weekend in West Virginia 2 weeks from now with a friend of mine?
I saw that look of dismay as soon as I
I did too. I was like, what's Renee wound up about with that?
Of all the places I would expect you to go, West Virginia would not be in my list of top 49.
Shepherdstown, West Virginia is like Dogtown, USA. You're allowed to bring your dog to the restaurant, a museum, anywhere you want. My friend of mine from college and I are bringing our dogs and meeting up at a bed and breakfast to hang out and go out to eat with our dogs. Wow. And catch COVID, apparently.
That's what I say. The only other thing in West Virginia is like the Greenbrier, and that's only if you want to have out from a nuclear attack or something. But other than that, so everybody other than Renee should be fine. But unfortunately for Renee, she won't be here on our next call because she'll be recovering from COVID at that point. So with that, I have nothing else. Nothing else new, nothing else exciting, nothing else in the land of vaccination or testing. So pretty much same old in that regards. So Shana, am I passing the baton to you?
Sure, you can pass it to me, but I'm going to pass it directly to Kate Sharma, who's going to give us an update about depression screening. And I'll let Kate go for it.
All right. Hello, everyone. Let me get situated. All right, so I made some nice, pretty slides. They are not the Accountable Health Partner approved slides, probably, but they are so pretty. So I'm going to give you a depression screening update right now. It's going to be pretty brief, but it'll be a nice transition into the next conversation that'll be had on this meeting. So again, here's my information. If you're out of practice, you've probably gotten an email from me. And I know that my name is confusing. My email is Kate Falone. It's Kate Falone Sharma, Kate Sharma, whatever. It's what happens when you get married and change your name. All right, so quick update for the Depression Screening Excellus Contract Quality Improvement Initiative. So just a reminder that what we're looking for as a change for practices is to have at least 75% of screenings done or a 15% increase in depression screenings. I have started doing 6-month outreaches to practices regarding the provider engagement report data that practices are able to view. So I have been sending nice screenshots of most recent data that you can see on the PER, with a couple updates on some things that our IT team has done, including adding a 2022 to 2023 toggle. So now you can jump from year to year to look at different year data. And I've had a couple practices kind of respond about asking questions or wanting to meet. Again, I am always happy to meet via Zoom, phone call, in person, whatever practices need, I'm happy to be there. As we move forward with this year, we're really focusing on follow-up. So we're going to be paying a lot of attention to that data, especially for practices who have the plan of care implemented into their electric EMR, Menin in particular, but there are others. And so I'll be looking through that data that we have on the back end of kind of how each individual practice is doing, and I'll start doing targeted outreaches. So if it looks like, you know, if we know that you have a plan of care implemented in your EMR and your data is still not showing kind of a big increase, I'll be reaching out just to make sure that like workflow is good and all of the data and tech and stuff is working properly. And then we can kind of discuss options on how to move forward and to make sure that we're capturing all of that follow-up that you guys are doing, which is we're so grateful for, and I know your patients are really grateful for as well. Also a reminder for practices who need a refresher, or for practices who are having, you know, kind of staff come and go, a little turnover. We're always happy to do PER trainings. We can do that in person. We can do that over Zoom. Elizabeth is very passionate about making sure that everybody feels really confident in understanding how to use the PER. And there's lots of little tips and tricks on how to download patient lists and how to filter through stuff. So we know that the PER depression screening is really the one thing that is, you know, kind of fully working on that, but we'd love to talk to people about it if they need just a refresher or a kind of walkthrough on that. And I think the other thing that I will say is we've heard a lot from practices on different options for when patients are screening positive for depression and what different resources are available. And so conveniently, George will be discussing the collaborative care model, which, you know, we're hoping will become a really great option for practices who need more resources for follow-up for patients who need a little more care. So those are my updates. If anyone has any questions, I'm happy to answer them now, or you can email me, call me, anything. So very brief update today.
Hey,
There is a question in the chat.
Sure.
for you, Kate.
Absolutely. Let me take a look. I'm not looking at my Zoom right now.
Okay, I can read it for you if you want.
Oh, okay. Yep.
Oh, Elizabeth answered it. Okay.
Oh, okay. Great.
For those of you who can't see the chat, though, the question is, how exactly does the plan of care, is that supposed to be documented for positive depression screenings? And Elizabeth just reads, there are several ways to satisfy the measure, but one of them is a plan of care, We've partnered with our BHI team to develop a plan, which is available in MedEnt, and are happy to work with practices to leverage that tool, build something specific to your practice, or build that content into additional EMRs. So just reading that for folks who can't see the chat or will be watching the recording later, so won't be able to view it there.
Thanks for answering that for me, Elizabeth.
And
All
if
right.
there are no additional questions, Kate's work in depression screening directly correlates to another project that AHP is working on, collaborative care models, and our partnership with Concert Health and all of those things. And Dr. Nazra is going to take it away and give us an update there.
Thank you, Jenna. I would also add to the plan of care documentation that's built into MedEnt that it's a checkbox, right? So there are several items that are built into the EMR. Obviously, we expect that, the practices are following up on those positive depression screening, but checking the box on one of those items would satisfy the measure in terms of follow-up in depression screening. The other way to follow up on depression screening that's positive is to implement an intervention, which takes us to the question of how can we embed, I'm sorry, give me 1 second here. How can we embed a behavioral health resource into your practice? The best studied and supported by evidence integrated care tool that we have model that we have is called the collaborative care model. So I'm sure that many of you on this call have, if not all of you, have heard of the collaborative care model. Just briefly, it's a model of care that's a little bit different from referring to an outside provider, in that the primary care provider in the practice remains the primary person responsible for the overall care of the patient, and that there's a resource in the practice or available to the practice, whether it's remotely or in person, to actually connect with the primary care provider and connect then with the patient and provide an intervention, a behavioral health intervention to that patient, document in the electronic records, and then consult on a weekly basis with a psychiatric provider, whether it's a psychiatrist or psychiatric nurse practitioner. And through that team-based approach of the primary care provider referring patients to an in-house resource, that's the collaborative care clinician, sometimes referred to as behavioral health care manager. That person actually is a mental health professional. So typically they are licensed clinical social workers or licensed medical social workers. So they are trained and able to provide psychotherapy, right? So although we call them collaborative care clinicians, and consultation with the psychiatrist or psychiatric provider on a weekly basis provides that element of supervision, as well as medication recommendations that is fed back to the primary care provider, and a decision is made on how to manage the patient together as a team. That's the model of care that we want to implement and scale through the primary care network, as well as our community partners. Now, if a practice wants to implement this model on its own, then obviously it requires that they recruit a collaborative care clinician, that they recruit a behavioral health therapist, and that's often the most expensive and the most difficult step, because those clinicians are not readily available. That's where the cost, it costs money until they start building a caseload and billing for their patients. Also, it requires adapting a workflow to identify patients and refer them and have this be a seamless model of care. The PCPs, because this is a different model from referring, the PCPs have to be aware of this model, buy into this model, say, oh, okay, so you're saying to me that my patients are going to be seen by a provider that's available to them even sometimes, even when I don't actually myself refer them. So based on a PHQ-9 score that's elevated, I'm going to feel comfortable and develop a trusting relationship with a resource to my practice to see those patients. There's an electronic health record built often to allow for this model to be managed, and then a billing, a charge capture and a billing model, because the billing for this model is not per patient per case or per touch. This is a billing model that is on a monthly case rate. So when the collaborative care clinician sees the patients, they accumulate minutes during that calendar month, and then a charge goes out once a month for that totality of the interventions provided during that month. This is different and requires a little bit of training for the billing team. Luckily, we have codes, specific codes approved by Medicaid, Medicare, and commercial insurers to provide that level of care. So who will benefit from a model like this? This model is really a population health level model of care. It touches patients and addresses patients' needs who have a high PHQ-9 score or GAD-7 score. There is significant evidence that patients who have behavioral health needs early on, like upstream intervention, who have mild to moderate depression as opposed to the more severe cases of depression, are better served by this model. Also, sometimes patients in crisis are served by this model because that resource is also available to address a crisis, but most of the patients are going to be those with mild to moderate behavioral health conditions. And also it addresses the needs of patients who are there in your practice, clearly are in need of a referral, but they will keep coming back to you and saying, no, I don't want to go to a psychiatrist, I don't want to go to a therapist, and I want to continue to receive my care at your practice. So you will have an additional resource to manage those patients. There is strong evidence that people in rural areas, and especially individuals with from racial and ethnic minorities, are at increased risk for reduced access. So there's a universal access problem for behavioral health, but more so for individuals from racial and ethnic minorities. And there is research that shows that the collaborative care model is actually effective in improving outcomes in racial and ethnic minorities. I included one of those resources in here. Move on. So you heard about our partnership with Concert Health. We talked about the collaborative care model before. We introduced Concert Health to you before. We are reaching out again to let you know that we want to talk to you individually, talk to your practice individually, explain this model more. I cannot explain everything that goes into this model in a 5 or 10 minute conversation, but we would love to have more time with you and address the need of your individual practice if you are willing to make time to invite us either through Zoom, or we are happy to also come in person to your practice and talk to you more about this model. We are working with this vendor called Concert Health. The benefit is that Concert Health will actually provide the collaborative care clinicians to us. So there's no need to actually go out and hire those licensed mental health providers. They are available through this vendor. They would be assigned to your practice. So it's not like a black box of 10 or 15 providers. It would be 1 or 2 providers dedicated to your practice that you would have a chance to meet, you would have a chance to interview, feel comfortable with their licensure and credentials, and we would implement this model only if you decide that this is the right model for you and this is the right team that's providing the support for your practice. Concert Health also would assist in implementing workflows. They have a long list of workflows, how to refer, how to manage the EHR tweaks and adjustments and builds, and then also about training your billing team to address billing for this model of care. So they would serve as a consultant to you as well as provide the clinical service. And like I said before, the billing is based on a per patient per month case rate. Now, how the business model works for Concert Health is that they would retain a significant proportion of the revenue that comes to the practice, and the practice will retain a small portion at the end of the day. But the value added to the practice is not necessarily in terms of revenue, but more in terms of service. This is just an example of how Concert Health looks at implementation, just as an example. And again, if we have a chance to meet with you and your practice, we would go into more detail about what step one in terms of planning, design, execution, go live, and then ongoing collaboration and improvement on the model over time. So again, Elizabeth and Kate and myself are reaching out to you today just to let you know that we are happy to hear back from you. If you want to reach out to us by email or maybe contact Jana if you have her contact information, and she will relay the message to us. And we either can schedule a time to talk to you, answer questions, or come to your practice. There is no commitment on your part. This is the phase where we want to share with you this resource and help you make a decision based on the information that we provide for you. Thanks, Jenna.
Hey, George. It's LJ. I'm just wondering, I recognize from past conversations that the collaborative care model is really focused on adult patients. And I know that the majority of the providers on the call here are pediatric. With you and Robin both on the call, I recognize some of the work that happens with our care managers and with Holly's consultation is not it's not specifically collaborative care, but there are aspects of that are, providing additional resources. I wonder if you all might comment on that, because as you're asking for outreach from folks about Concert Health, I believe you're asking for outreach from practitioners who are caring for adults, and just clarification around that would be great for the people on the call.
Yes, thank you, LJ. That's correct. So this model, although in some places has been implemented in pediatric population, for us at AHP, we want to focus on the adult population. However, we would welcome still calls from the pediatric providers and hear what the needs are. Holly and I and LJ and others can sit down and give you information on what's available as far as resources, as well as what we are trying to build as far as additional services, similar but not exactly the same as the collaborative care model.
Yeah, I appreciate you said that, George, because I think that actually we have a high priority focus on children and youth, considering the mental health crisis that continues to evolve and is clearly contributing to the bulk of the patient care time and outside of patient care time that our primary care providers are providing. I think the key thing is engaging with, and I just want to highlight what you said, engaging with our primary care teams, with the pediatricians, with the family medicine physicians caring for kids, and make sure that what we develop will be as effective as possible and not redundant to other services that they have. So we will be looking as we prioritize our efforts this fall, we will be looking at working with your practices to develop increased services in that space, building on the success of our social work care management team. Robin, I think I cut you off and I apologize for that. I just realized you unmuted.
I just wanted to, one of the ways that I like to think about this for my own clarity is when we think about the interventions that are offered to our pediatric primary care offices, it's almost as if there are tiered levels of intervention. So right now, the social work care managers that are currently deployed across our 24 pediatric offices are working with the most complex patients. So in addition to maybe a mild or moderate depression, they may have a number of other things going on. So they may have school-related issues. They may have intellectual or developmental issues going on. They may have family trauma or environmental or psychosocial risk. So those referrals are really the highest level and truly need kind of a full wraparound community-based approach in multiple systems and sometimes in multiple levels of care to fully meet that patient and family need. Collaborative care, as George had mentioned, is the way I view it, a tiered intervention, that it is just kind of a notch down from that complex care management. So those individuals are ready, they are willing and able to participate in some evidence-based intervention. Their depression is not so severe, but it is the rising risk. And they're ready for intervention and they're ready to, accept something that is, available to them right away. So when I think about the social work care management, I think about it in terms of those referrals that might interface with more complex systems in our community, whether it's mental health, OPWDD, school district related issues, where the social workers are out and about doing that community linkage and work on those levels, also providing some brief intervention, and may in some instances work with outside therapists or even collaborative care therapists, depending on the need. There really are tiered, as we all know, there is an enormous amount of need, and meeting that need effectively and efficiently and with the skills is really important. So collaborative care definitely has a huge role in a population that is really the rising risk, and can definitely, use and benefit from that intervention at that primary care level.
That's very important, very helpful, Robin. Collaborative care is one intervention on a continuum of care, and it's not a solution by itself to all the problems. That's very well said. Thank you.
Okay. If there are no questions, I don't see any in the chat right now. I'm going to let Robin keep talking, but before I do so, I want to let you guys know that Robin was recently promoted to be as AHP CMO Clinical Manager of Maternal, Child, and Family Care Management. And so she's going to be talking about one of the teams and the projects that she's working on. I don't even want to call it a project because it's more than that, in that new expanded role. So congrats again, Robin, and take it away.
Oh, thank you. I'm glad you said that title. It's a mouthful. So, again, for those who are less familiar with me, I think, most of the pediatricians are familiar with me who've been around since the start of pediatric care management. I oversee the pediatric social work care managers, and we have currently, I think, 23 or 24 community-based offices, and we have 9 master's prepared social workers, LMSWs, LCSWs. They are providing support across our network of 24 practices. Like we mentioned earlier, there is tremendous need for different levels of support. One of the ways that we have evolved as a team is in thinking about the needs, and of course, those complex needs. There are the needs for brief intervention, and there's also needs for community intervention related to social determinants of health. What we have done recently is expanded our team by 2 professionals, Megan Willis and Brianna Seawright, who are on this call. These ladies are bachelor's prepared social workers and are experts in really that community-based boots on the ground work. We're calling them our pediatric outreach team. And their role is to work with our social work care managers with the most complex cases, which seem to be more of the norm. But the goal being to reduce immediately some of those social barriers: transportation, food, diapers, loss of insurance or inadequate insurance, housing or temporary housing. The focus on that has to happen first. When that happens, and in tandem with our PEDS outreach team, our social workers can then move into those larger systems of work, working with the schools, working with OPWDD, our Office of Mental Health levels of care. The goal is to create better access and to improve equity to our community. And this is one way that we're doing that. And it also is allowing us to have our social workers working at the top of their license and in a team-based format for some of these complex families. So we're delighted they're here. This is a new model that we're working on, and slow but sure, they're working on referrals and doing a wonderful job. So thank you for letting us talk about them for a little bit.
So you got to come up with a better name than TOT.
Huh?
So you got to come up with a better name than POT.
The POWs, I mean, pediatric outreach workers. I mean, I don't know. I don't know. Brianna, Megan, they're miracle workers. They're boots on the ground. Okay, we'll brainstorm.
So you got to work on the acronym. We got to come up with something.
Okay.
Okay. Barring any questions for Robin or Brianna or Megan, we can move on to the very last item that we have on the agenda, which is actually for me to discuss. And it's just a really quick update on something we became aware of in the spring regarding the VATICA program. For those of you who don't know, VATICA is a risk coding program that AHP is partnering with our major payers, Excelis and VATICA on, so that we can help along, capturing adequate coding for those patients who might have chronic or complex health conditions. Earlier in the spring, we became aware and we were alerted to the fact that one practice was receiving $150 per encounter as opposed to the higher $175 per encounter incentive that we had negotiated with Excelis and VATICA. And so what we did once becoming alerted to that is we asked that Excelis performed an audit of the 2021, 2022, and first quarter 2023 payment distributions. Upon that review, they did not find any additional payment errors, that one practice was made whole. And so moving forward, we don't think that this is going to be a continuing issue, and we don't think that there are others who are impacted by it. But our recommendation right now is to just make sure that you're checking the amount that you receive for your incentives. That higher rate is only for Excelis lines of business, so Excelis Medicare, commercial, and Medicaid products. And something to be cognizant of is when VATICA makes that payment to the practice for incentives on a monthly basis, it includes all of the participating payers. So while we've negotiated the rate for Excelis to be higher, if you have patients that you do VATICA for MVP, Fidelis, Humana, WellCare, any of those other products that are partnering with VATICA, it is not, relevant to those products. So just, make sure that you're looking at your Excelis members for your Excelis lines of business for that $175 per encounter. That is really the only update there. For those of you who are unaware about VATICA, again, we are, looking for people who are interested in practicing or participating in the program, I should say. This is something that's included as a citizenship component for your AHP PCP reward plan, and it's available at the provider level. So if you're looking for different ways to get engaged with AHP, this is a great way to do that. It can help with bringing in some revenue, and it can also help with your AHP PCP reward plan. At the moment, I know I've gotten a lot of questions about whether Vatica is available for pediatrics. At the moment, it is not. We have put the ask out because, over the last year or so, we've gotten a lot of interest with the pediatric practices. And Vatica did just recently expand to include Medicaid. So, that is something that I've asked that both groups look into to see if there would be an opportunity there. So hopefully there's more to come there, but as of now is not available for pediatrics. With that being said, that is the very last item on the agenda. We might be able to give folks 8 minutes of their time. Renee, Chad, LJ, anyone who chatted today, George, any other things that you'd like to add to the call? No?
Jenna.
No, I think we're all good.
Yep. All
All
set.
right.
Thank you, Jana.
Yes.
Thanks, folks. Look
Enjoy
out for
your-
the follow-up.
Take care.